If you've Googled your AMH hormone level at midnight, you're not alone. You probably came across some conflicting information that made you more anxious than not. I'm Dr. Sharon Moayeri, owner and founder of OC Fertility, and I'm here to talk about what it means and how to interpret it. You've probably had this hormone level given to you without much explanation. By the end of this video, you should have a better understanding of what AMH or anti-Müllerian hormone is, what it means, and how to interpret it, so when you meet with your doctor, you'll be able to understand its importance. So what is AMH and why does it matter? AMH stands for Anti-Müllerian Hormone. It's a hormone that's released directly from the ovary. As women, we're born with all our eggs. So the higher the AMH, the more eggs you have because it comes directly from that tissue. Anti-Müllerian hormone is often misunderstood because women often think that it directly corresponds to either how fertile they are or how healthy their eggs are. It has nothing to do with the quality of your eggs, although the younger you are, the higher the AMH is. And so, of course, the younger you are, the healthier your eggs are because they've been with you for less time. Now, some young women do have lower AMH hormone levels because they may have depleted their eggs sooner, but the advantage they still often have is that they're younger, so the quality of their eggs may still be better. So AMH is strictly an egg quantity hormone level, and it really predicts more how you're going to respond to treatment. It doesn't tell us whether or not you're going to get pregnant, but if you're younger and you're starting out with a lower AMH hormone level and maybe you're not ready to start your family, you may want to know that, especially if you're thinking about having multiple children, because over time that AMH hormone is going to decline because over time our egg count goes down since we're born with all the eggs we're ever going to have. So it is a valuable hormone level to understand and to know, even though it's not necessarily going to directly predict your pregnancy rates. The test is done through a blood draw. It has to be analyzed in a very specific way. So you want to make sure that when you're having it drawn, you're doing it with a specialized practice or a lab that understands and standardizes this test. It should correspond to another analysis called an antral follicle count, which is an ultrasound. So you don't want to just do the AMH outside of the context of other fertility testing. It corresponds to an antral follicle count roughly by a factor of about 10, meaning if you have an AMH of 1, I expect to see about 10 antral follicles on ultrasound. There's some reasons why these may not align, and that's important to understand, which is why we want to be able to do both in the same patient at roughly the same time. There's other hormones we also look at called FSH, follicle stimulating hormone, and estradiol. And of course, the age of the patient really matters. So sometimes patients ask what's a normal AMH, and I like to say there's really no specific normal AMH, it's really age normative. So what's normal in a 30-year-old is very different than what's normal in a 40-year-old. Oftentimes you'll hear 1 as being a normal value, but for a 30-year-old, 1 is actually considered on the low side, versus for a 40-year-old, I expect 1 to be considered a good value, higher than what I'd expect for the average 40-year-old. So using normal and abnormal values doesn't really make sense necessarily when you're talking about AMH. You want to consider age normative. So what I expect for this particular woman in her age group is a better way to consider AMH. Different from other hormone tests that we do related to fertility, AMH can be done at any time of the menstrual cycle versus follicle stimulating hormone. Follicle stimulating hormone and estradiol fluctuate throughout the menstrual cycle. Those need to be done between cycles day 1 and 3. AMH can be done at any point of the menstrual cycle. AMH can be influenced by obesity or body weight. It can also be influenced by vitamin D levels. So there are some reasons why AMH may not be reliable. We do want to also mention that on the extremes, it may not be very accurate. So very low values and very high values tend to be less accurate. I generally tell my patients low is low, very high is high. And we do tend to see very low values in older patients or patients with diminished ovarian reserve. And we do tend to see very high values in patients with something called polycystic ovarian syndrome. AMH can be prognostic in patients going through treatment. In other words, we do use it as an indicator of a patient's success with treatment in terms of understanding how many eggs they're likely to get. We do know that when a patient's able to get double-digit number of eggs, they're generally going to outperform women who aren't able to get double-digit number of eggs. So an AMH of 1 roughly corresponds to a potential to get 10 eggs at a retrieval, and patients who are able to get at least 10 eggs outperform patients who aren't able to get 10 eggs at a retrieval. Now, of course, this really depends on the age of the patient and the quality of the eggs as well as the partner's sperm, but these are just rough estimates of performance based on the AMH, taking into account, of course, egg and sperm quality as well as the age of the partners. Sometimes I'll get a patient who comes from their OBGYN and is told that their AMH is very low, for instance, at 40, and maybe it's at 0.8. But 0.8 for a 40-year-old is actually very normal and what I would expect for that age group. Or maybe they have an AMH that's 1.5 at 40 and they're told that they're fine and they don't have to worry about fertility. Age is still the most important predictor of a woman's fertility, not her AMH level. So age and history are the most important predictors. And in fact, I'd say history is probably the most important predictor. If you've had a long-standing history of infertility, you've been trying for months and you're not getting pregnant, that is more important than your AMH level. So sometimes I'll see patients who come to me, maybe they're not even trying to get pregnant, or maybe they're doing sex selection, and incidentally they're found to have a low AMH and they're panicking. Low AMH in a younger patient can be fairly meaningless when they're trying to conceive naturally, because AMH, again, is a predictor of how we're able to recruit eggs with treatment. So in other words, every month when we ovulate, we're only ovulating 1 egg at a time, but we have a group of eggs that theoretically could be recruited during treatment to ovulate. Those eggs would otherwise have just shed off the ovary. So during treatment, if I see a patient who has an AMH of, say, 0.5, maybe I could get half a dozen eggs if I gave them the right medications. Those patients are now concerned because their AMH is less than 1 and they're in their, say, early 30s, and they're worried that they're not going to be able to get pregnant. What I tell them is, if you want multiple children, there should be maybe a concern because you're starting out lower than expected, and we expect that AMH to decline with age. And so you might want to consider some fertility preserving options, or at least to consider trying to get pregnant sooner than later to make sure that you don't have any other risk factors, because the best way to find out if you're fertile or not is to try to conceive. But low AMH itself is not necessarily a predictor of your current fertility potential, because you're only going to be ovulating 1 egg at a time anyway, and it doesn't tell me if that egg is healthy or not. And so certainly we have people walking around with low AMH who don't even know it, who are getting pregnant. But if they're considering doing treatment, it could predict their response to treatment. And if they want to delay having children, we know that that hormone's likely to go down with time. I just can't predict the future to know how quickly it's going to go down with time, and that's the hard part. So having a low AMH at a young age could predict poor future fertility, and that could be a risk factor if they're planning on having multiple children. So it might be worth considering testing the AMH at a young age to see if you're starting out lower than expected for your age group, especially if you're going to be delaying having children. But it in and of itself is not necessarily an indicator of whether or not you can get pregnant. Another point about a low AMH is I have no way of predicting how quickly it's going to change. I can only tell you where it's at today. The pace of decline is impossible to predict, although we do know that there's roughly 2 times in a woman's reproductive years that we do tend to see rapidly declining fertility. Her early 30s, somewhere around 32-ish, 33, and then again pretty quickly around 37 to 38, especially when it comes to quality of the eggs. Now, another thing that people often overlook is what's considered a high AMH, and people think the more the better. But when we see a high AMH somewhere around 4 or greater, we do want to consider a condition called polycystic ovary syndrome. Polycystic ovary syndrome, or often called PCOS, is an endocrine disorder. We refer to based on the characteristic of the ovaries, but in fact it's more related to a hormonal imbalance, with excess androgens being the primary characteristic. So high free testosterone, total testosterone, or adrenal gland hormones, DHEA, sulfate. So this condition runs in families. We see it often associated with mothers and daughters and sisters, and we do often see diabetes and heart disease in these families as well. High cholesterol is another common finding, as well as prediabetes. So when we find women who have these high AMH, it's definitely worth screening for polycystic ovary syndrome, even if they don't fit the stereotypical characteristic that we see with polycystic ovary syndrome. It can sometimes be hard to diagnose, especially in areas such as where I practice, where people are very health conscious, because sometimes they're managing their PCOS very well with lifestyle. So you want to do blood work and then really dig deep into their menstrual cycles. Even with normal menstrual cycles, some people aren't ovulating, and that's one of the hallmarks of polycystic ovary syndrome, or maybe they're not ovulating normally. And then you want to check their androgens, like I mentioned previously, the testosterone and free testosterone, as well as the other androgen levels. Polycystic ovary syndrome can be associated with infertility, partly because of irregular ovulation, but there's other reasons why women with polycystic ovary syndrome may have infertility as well. Sometimes with the other medical conditions that go along with polycystic ovary syndrome, you might see lower egg quality. And then sometimes we see lower egg quality related to the inflammatory processes that are associated with PCOS as well, especially if there's obesity in conjunction with the PCOS. Women with PCOS, especially when their AMH is very high, so greater than 4 is considered high, but we have patients who have AMH levels in the teens and even in the 20s or higher than that. And those patients can be very resistant to some of the common medications that we use to induce ovulation. They also may have some irregular stimulation response to medications, and so those protocols should be adjusted accordingly. They might not respond as well to the typical IVF protocols. They may not get synchronized egg development. So it's important to recognize those patients to modify their protocols accordingly. So I'm often asked, well, what can I do about my AMH? Can I do anything to increase my AMH, or can I do anything to decrease my AMH? Well, you can't really increase your AMH necessarily because, again, as women, we're born with all our eggs. So if you think of a sack of eggs, that's your ovary. You're born with about 2 million eggs. By the time you hit puberty, you might have 500,000 eggs. By the time you're in your late 30s, you've got about 10% of your remaining ovarian reserve. So you can't increase that number because they're constantly shedding from the ovaries, the eggs. So what can you do about your declining AMH? You can potentially slow the process down by leading a good lifestyle and trying to be as healthy as possible, just like you can with any other kind of aging process. You can do things to reduce the risk of the process becoming worse. So I recommend, clean lifestyle, making sure nutritionally you're adequately supported, making sure that you're lowering stress and inflammation in your body as much as you can. In terms of lowering AMH for women who have PCOS, in the old days we used to do things like resection of the ovary or drilling of the ovary. We don't really recommend those things these days, but over time your AMH will decline because the ovary will shrink over time due to aging, normal aging process. Sometimes women with PCOS who do have very bulky, large ovaries will have resumption of normal cycles as their ovaries decline in size. And that can be the reason why you see that women with PCOS, when they're younger, have irregular cycles and then start to normalize as they get older. And in their head, they feel like maybe they were misdiagnosed with PCOS because they had irregular cycles when they got the diagnosis, and now they're having normal cycles. And it's hard for them to understand why they got this diagnosis that doesn't align with where they're at today. But PCOS can really change throughout a woman's life. It's really more of a risk factor and a genetic condition. Even though its presentation can change over time, once you have the condition, you're always going to have this risk factor. It doesn't go away. It's almost like considering in your family that you have heart disease. You have it. It's just that you can either declare it with lifestyle and age and weight, or you can keep it under control sometimes with lifestyle and weight control and management. So PCOS is really a hereditary condition, and sometimes it can be managed well with lifestyle and diet, and other times it's difficult to do so. The last thing to remember is that AMH is not an indicator of egg quality. It's very difficult to predict egg quality aside from a woman's age and history. So a couple, especially a young couple who's having a long history of infertility, one of the concerns we often have is egg quality or sperm quality. But age is definitely a predictor of egg quality, especially as a woman gets into her late 30s and certainly once she gets into her early 40s. The only way to really know about egg quality is to get the eggs out of the body, although FSH is potentially an indicator of egg quality more so than any other hormone that we can evaluate. So to summarize, AMH alone is not an indicator of whether or not you can get pregnant. It does help us predict your response to treatment, but more importantly, what we want to know is whether or not your eggs or embryos ultimately are viable and healthy, and it can help us predict how many treatments you might need to achieve your goals. But in the end of the day, AMH is just one parameter of many parameters that we need to predict what kind of treatment you need, and whether or not you're going to be successful with treatment. So here at OC Fertility, we're happy to do a consultation to talk to you about what your best treatment options are and to understand what those hormone tests really mean for you. If you found this information useful, I'd love for you to subscribe to my YouTube channel.